Hello everyone, this is Nicole Freeland for Nursing 101 Pharmacology, and today we are discussing Module 2, which is Safe Medication Administration and Error Reduction. Your objectives for this module will be to discuss nursing implications and concepts of safety when performing medication administration. You must describe the role of the U.S. FDA in determining the safety of drugs for use by the population, and you should be able to identify measures that support safe medication administration. As the nurse, you will have an incredible amount of responsibilities. When it comes to medication administration, your responsibilities as a nurse will be to know the federal, state, and local laws regarding medication prescribing, dispensing, and administration of medications. You should know the medications and all implications of that medication before administration. You need to evaluate the response to medications. You must maintain practice and skill competencies when it comes to medication administration. You should determine the accuracy of all prescriptions. You are responsible for reporting all medication errors. You must ensure that the medications are properly stored. You should follow laws, both federal, state, and your facility's policies when administering controlled substances. And you have to be able to calculate medication doses accurately. So when I talk about knowing the medications and all implications involved with that medication, what I am discussing is the medication class or category. This will describe the pharmacological action, the therapeutic use, the body system it targets, its chemical makeup, and the classification for use of the drug during pregnancy. And then there's the mechanism of action. This is how the medication produces their therapeutic effect. Then we have the therapeutic effect. This is the expected effect for which the nurse administering a medication should expect. We have side effects. These are the expected and predictable effects that result because of a therapeutic dosage. We have adverse effects. These are undesirable, inadvertent, unexpected, and potentially dangerous responses to medications. And then we have toxic effects. This is when medications have specific risks and manifestations of toxicity. They develop after taking a medication for a long time or when toxic amounts build up due to faulty metabolism or excretion. Then you must know the medication interactions and compatibility. Medications can interact with one another, resulting in beneficial or harmful effects. You must obtain a complete medication history and be knowledgeable of clinically significant interactions. If you are giving IV medications, you should know if that drug is compatible with the other medications running through that IV line, or do you need to obtain a second IV site? You are also responsible for knowing the precautions and contraindications when giving that medication. These are conditions like disease, age, pregnancy, even lactation, that may make it risky or completely unsafe for clients to take a specific medication. You need to know the correct preparation, dosage, and administration route for that medication. It's important to know any specific considerations for preparation, safe dosages, dosage calculations, and how to administer the medication. And then you need to know the nursing implications involved with giving that medication. Know how to monitor the therapeutic effects and the side effects. Prevent and treat adverse effects, provide comfort, and instruct clients about the safe use of medications. little bit about medication categories and classifications. So when we talk about medications, there are 3 different names that you need to keep in mind when we discuss medications. There's a chemical name, a generic name, and a trade name. The chemical name is the name of the medication that reflects its chemical composition and its molecular structure. A generic name is the official or non-proprietary name the United States gives a drug, and each medication only has one generic name. An example would be ibuprofen. A trade name is the brand name or a proprietary name the company that manufactures the medication gives it. One medication can have multiple trade names, like Advil or Motrin, which are all trade names for the generic medication ibuprofen. Then there are controlled and uncontrolled substances. Uncontrolled substances require monitoring by a provider, but do not generally pose risk of abuse and addiction. Antibiotics are an example of an uncontrolled prescription medication. Controlled substances have a potential for abuse and dependence and have a schedule classification. For instance, heroin is a Schedule 1 and has no medical use in the U.S. Medications Scheduled 2 through 5 have legitimate applications. Each subsequent level has a decreasing risk of abuse and dependence. For example, morphine is a Schedule 2 medication that has a greater risk for abuse and dependence than phenobarbital, which is a Scheduled 4. Now we'll talk a little bit about prescription communication. And part of that is receiving an order. So providers or nurses who take verbal or telephone prescriptions from a provider write medication prescriptions on the client's medical record. When the nurse writes a medication prescription on the client's medical record, the facility's policy specifies how much time the provider has to sign the prescription. Nurses simply transcribe medication prescriptions onto the medication administration record. When you take a verbal order, you will take down the information or the components of a medication prescription. It is the same for a telephone order. You will need to include the client's full name, their date and time the prescription was received, the name of the medication, the strength and dosage of the medication, the route of administration, the time and frequency of a medication. This includes exact times, intervals, or number of times per day, the quantity to dispense and the number of refills, and the signature of the prescribing provider. We have different types of prescriptions that you will encounter when you take an order for a medication. The first kind are routine prescriptions. These prescriptions identify medications nurses give on a regular schedule with or without a termination date or a specific number of doses. Without a termination date, the prescription remains in effect until the provider discontinues it or discharges the client from the facility. Providers must re-prescribe some medications, such as opioids and antibiotics, within a specific amount of time, or they will automatically be discontinued. A one-time prescription are for administration once at a specific time or as soon as possible. These prescriptions are common for preoperative or pre-procedural medications. For example, a one-time prescription instructs the nurse to administer lorazepam 2 milligrams IM at 0700. Stat prescriptions are only for administration once and immediately, typically in emergencies when a client's condition changes suddenly. For example, a stat prescription instructs the nurse to administer diphenhydramine 50 milligrams IM stat. PRN prescriptions specify at what dosage, what frequency, and under what conditions a nurse may administer the medication. The nurse uses clinical judgment to determine the client's need for the medication. For example, a PRN prescription instructs the nurse to administer tramadol 50 milligrams PO every 4 hours PRN for back pain. When administering PRN medications, the nurse documents findings that demonstrate the client's need for the medication and the time of administration. And please keep in mind, if you are giving a pain medication, you need to assess their pain level. And then if you're giving an oral medication, after 30 to 45 minutes, you need to reassess their pain level. It's also important to note that PRN prescriptions cannot include a dose range of 1 to 2 tablets. If it states 50 milligrams to 100 milligrams, that order is incorrect and it needs to be clarified with the physician. And then we have standing prescriptions. Providers write standing prescriptions for specific circumstances or for specific units. For example, a critical care unit has standing prescriptions for treating clients who have asystole. Another example is a heparin protocol. More examples would be sliding scales for insulin and medications that may be given in labor and delivery, such as oxytocin. So before you go to give a patient a medication, you need to confirm all of the following. You need to verify their allergies. You need to confirm their age, and that is because the younger or the older a patient is, the different effects a medication can have on these patients. If you have a very young patient who does not weigh much, their dosage is going to need to be much less than that of an adult. Whereas if you have an elderly patient, there may be issues with metabolism that would require them to have a decreased dose of a medication. You need to confirm the patient's understanding of the medication. This patient needs to know why they are being prescribed and taking this medication. You do need to confirm the correct dosage for that particular patient. You do need to confirm the client's med list. A med reconciliation should have been done before you administer any medications. That way, you are able as the nurse to assess if there is a medication contraindication. You need to inquire about possible substance abuse. Is your patient taking any recreational drugs that would inhibit or alter the metabolism of the medication that you are going to give them? Is it safe to give them? And then you also need to perform a physical assessment before you administer a medication. One example would be you need to obtain a blood pressure and pulse prior to administering cortisone to a patient, because if their blood pressure or pulse is too low and you give them this medication, it could cause them to drop significantly, that both their pulse and their blood pressure, and it could be potentially fatal. These 6 rights of medication administration, you always, always, always have to verify these 6 rights before you administer a medication. You need to ensure that you have the right patient. You may know that the patient is in bed 284. You may have pulled out the correct medication for the patient in bed 284, and then you enter into room 284, and there are either 2 beds, or perhaps the patient's up to the restroom and a dementia patient has entered that patient's bed. So you need to be aware that you are in fact administering the correct medication to the appropriate patient. You will do this by verifying the patient's wristband, and then you will have them repeat to you their full name and date of birth to you, and you will verify that with their wristband. You need to ensure that you are giving the right medication. You pull the medication from your Pyxis or your Omnicell, and it pops open a drawer for you, and you immediately take that medication out without looking at it. You pop 1 pill into your med cup, and you go to give that to your patient. What happens if pharmacy loaded that Omnicell wrong? Because we're not perfect. And so if you don't check the label of the medication that you are administering, you are missing this right of medication administration. So when you go to pull a medication, you need to always check the label of the medication that you are pulling for your patient. You need to ensure that it is the right dose. So when you are looking at the label, you need to look at the dosage that you are getting out of the Omnicell or the Pyxis. Do you need 1 pill? Or is your order for 100 milligrams, but you have 50 milligram tablets? In that case, you would pull 2 tabs. Are you giving it at the right time? Are you giving it within the allotted window of time according to your facility's policies? If you miss a dose, do you give it as soon as you miss the dose and you realize that you've missed it? Or do you skip that dose and you give it at the next administration time? If it's an antibiotic and you are late on administration, you will give that dose when you realize that it has been missed, and then you will alter the administration time from that dose on. Is it being given by the right route? You may receive an order to give 25 milligrams of Phenergan to your patient. Is that medication supposed to be given IM or IV? You need to know that you are giving it in the right route, because it can have fatal side effects if you give it in the wrong route of administration. And then you need to ensure that you are documenting that medication the correct way. You need to document it under the correct patient, at the correct time, what route you gave that medication, if the patient tolerated that medication administration well, and then you need to document their response to that medication. Was it therapeutic? Did they have adverse side effects from that medication? All of these must be in place to make sure that you are giving a medication appropriately. And then on top of those 6 rights of medication administration, you also need to inform the client about the medication itself, its purpose, what to expect, how they should take it, and what to report if an adverse reaction occurs. You need to individualize client education, determine what the client already knows, what they need to know, and wants to know about the medication. You need to know that the patient has the right to refuse any medication. Respect the client's right to refuse. Explain the consequences if they do not take their medication, inform the provider, and then document their refusal. You need to ensure right data collection, collect any essential data before and after administering the medication. For example, measure the apical heart rate before giving digoxin. And then the right evaluation. You do need to follow up with clients to verify therapeutic effects, as well as side effects and adverse effects after you give a medication. Let's talk about medication errors. Medication errors occur because we are only human. Errors happen. The important thing to remember is that once you realize you have made a medication error, that you report it to the physician immediately, you report it to your charge nurse, you assess your client, and then you do need to fill out an incident report. Wrong medications can be given because of look-alike, sound-alike medications, or perhaps, like I discussed just a bit ago, the pharmacy loaded the wrong medication into the wrong drawer of your Omnicell. A wrong dose can be given. You can give too much or too little of a medication. As I stated, you can give it to the complete wrong client. If you're working night shift and it's 4 a.m. and you're giving 4 a.m. medications, you may be tired, you may be sleepy, you may know where room 282 is, but you accidentally walk into room 280 and you give that patient 282's medications. It could be that a dementia patient is lying in the wrong client's bed. Any number of things can happen, and that is why you always ensure that it is the right patient receiving the right medication. You can give a drug by the wrong route. You can receive an order for a medication, give this medication X amount now, and perhaps you didn't verify all of the correct components to a medication order. Or perhaps the physician didn't provide you with all of the correct components to a medication order, and they hang up on you. And you assume you know what route that dose needs to be given, and so you go ahead and give it. And then that can have very, very fatal side effects to it if you do not verify all proper components of a medication order. You may give a medication at the wrong time. You can give a medication too early. If someone fills out the EMAR incorrectly, or they forget to chart a dose, you then go to give the next scheduled dose, assuming that that medication had been given, and it's the wrong time. They didn't receive their antibiotic every 4 hours. Maybe they only received it 2 hours apart because the last nurse was late on their administration. So always, always verify documentation and your MAR before you go to give a medication. You actually may give an administration of a medication that a patient has an adverse effect to, or even an allergen to. Oftentimes physicians will prescribe medications without being aware of a patient's allergies, and you as the nurse need to inform the physician of their allergies before you receive a medication order. However, if that physician writes an order for a medication that a patient is allergic to, and then you go to give that medication and you don't check their allergies as well, then you are at fault and have made an error. And there are serious side effects that can incur because that happened. You may discontinue a medication at the wrong time. Perhaps your IV runs dry and you as the nurse decide to stop it. And then you come to find out that that patient is still NPO and they have a procedure scheduled for the next day. That was an incorrect discontinuation of a medication. And then there's inaccurate prescribing itself. That includes inaccurate prescribing of medications if a patient has an adverse effect to that category of a medication, or perhaps they're allergic to that medication, or perhaps they are receiving another drug that would greatly contraindicate or interfere with a new prescription. These are things that you have to be responsible for checking as the nurse. Preventing medication errors is very important because of everything we just talked about. So you, as a nurse, must verify the prescription accuracy. You should obtain clarification if necessary. Like I stated before, if you receive a PRN medication order, give acetaminophen 1 to 2 tabs, PO, Q6 hours, PRN, headache. That's an incorrect order, and you need to call the provider and ask them to clarify their order for you. Verify the medication schedule. So you will always look at your MAR, and you will look at the last dose given before you go to give your ordered medication. You verify the diagnoses of your patient. Why is your patient receiving this medication? Are they receiving a medication but they're diabetic and this medication is contraindicated for diabetic patients? Or are they receiving a medication that's contraindicated for a heart failure patient? Would it have toxic side effects on their cardiac system? Would it have toxic side effects on their liver or their kidneys if they're in renal failure? You need to verify your patient's diagnoses, all of them, before you administer a medication. So that way you know if you are giving a medication that is inappropriate to that patient. Gather pre-administration data, like we talked about earlier. Assess your patient, their allergies, their correct name, their vital signs before you give medications. And then you will always verify the 6 rights at the bedside with the patient. Let's talk about some things you should not do when you are administering medications for patients. You should not become distracted. When you are standing at your Pyxis, your Omnicell, your MedCart, and you are drawing out medications for a patient, perhaps the phone rings, a call light goes off, another coworker asks you a question or asks you to come help them move Mrs. H up in bed. You have to first either put your medications back in the correct spot or finish drawing out your medications before you leave that area to do another task. You should never, ever prepare multiple clients' medications at once. You may be working night shift, you may be short-staffed, there may be 4 call lights going off, and you think to yourself, okay, I know that this is what this patient receives. I'm going to draw it out, and that's going in my left pocket. And then Mr. J is just down the hallway, so I'm going to draw out his medications at the same time. Those are going in my right pocket. And you get to those patients' rooms, and you are so distracted. It's so hectic at work. It's 1 a.m., and you just pull out the wrong cup out of the wrong pocket and give that to your patient. Don't ever do that. Do not assume the medication is correct when you are dispensing it. That goes back to checking all labels before you pop a medication to give it to your patient. Do not ever bypass the 6 rights of medication administration. Never, ever bypass the 6 rights of medication administration. That will always lead to medication errors. Do not forget to check the MAR. Always check the MAR before you give a medication. Perhaps the last dose was given later than you assumed it was. Perhaps that medication had been discontinued and no one told you at shift change when you were receiving a report. Whatever the case may be, always check your MAR before medication administration. Do not leave medications at the bedside. This is so important. Your elderly patients can drop medications into their bed. Your elderly patients may spit their medications out into the trash bin at the bedside. You may have patients that give their medications to their friends that are visiting them. You as a nurse are legally responsible to ensure that the correct patient has received the correct medications. So you have to visualize and watch that your patient actually takes these medications, then you document that, and then you know that you are monitoring that patient for the correct side effects that may incur after medication administration. If a client tells you that that pill does not look correct, or that they've never taken that medication before in their life, well, this is This is a blue pill. I always take an orange pill. We know as the nurse that there are different manufacturers for different medications. However, your client does not know that. But with that being said, a lot of times your clients know their own health history, their own bodies, their own medications better than we do as a nurse. You need to keep that in mind. And if a patient expresses a concern to you about a medication you are trying to give them and they are adamant, you need to leave that patient's room with the medication, and you need to verify the order and the dose, and you need to check the EMR to make sure that all of those are in place before you then give that medication to your patient. A lot of times patients are correct when they tell you concerns and they tell you they shouldn't be taking that medication. A lot of times there's a reason that they should not be taking that medication. Perhaps there's a contraindication for that medication because of the other medications they are taking, and their provider is unaware of their other medications that they are taking, and so they prescribe that medication anyway. You as the nurse are responsible for recognizing these certain things. You're responsible for recognizing that it's the appropriate, safe medication for your patient. So if a medication error occurs, what would you do? First of all, as a nurse, I have made medication errors in the past. I can tell you that the best thing to do is to own it. If you realize that you've made a medication error, you must fill out an incident report. And it's always best that the individual who made the error fill out that report. If you are looking at a MAR and you notice that a nurse has made a medication error, or you witness them making a medication error, do not do this in front of the patient or even other coworkers, but ask them to step aside very politely and tell them what you have witnessed. It will then be up to them whether they would like to fill out the incident report or not. If they do not wish to fill out the incident report, then you need to report that error to your charge nurse, and then it is your responsibility to fill out the incident report since the individual that made the error will not. Incident reports need to be completed within 24 hours of the incident or according to your facility's protocol. You must identify the client that was involved. You need to identify the medication and the dose that was given, or if a medication was not given. You need to document the time and the place that the incident occurred. So room 287 at 03:57. You need to provide accurate and objective events. So exactly what happened, objective events only. That is just exactly for factually what happened, not how you feel, not how the patient felt. Those are subjective events, that's subjective data, and you do not include subjective data in an incident report. You must notify the charge nurse, and you should probably also notify the provider and document that they were notified. It says notify charge nurse and or provider. It's always best to notify both of them. Perhaps your charge nurse wants to be the one to notify the provider. Oftentimes they won't want to. If it's your error, you need to be responsible for notifying the physician. What actions were taken after the error was noticed? Did you go reassess your patient? Did you take their vital signs? Did you report the error to your charge nurse? Did you call the pharmacy to report the error so that they could give you instructions as what should be done next? If there is anything they can do for this patient, is there an antidote for that medication? You need to correctly document all actions that were taken after the error was noticed. Like I said, it's best to complete your own report, and do not reference an incident report on the medical record. This is important because you cross into legal aspects here in nursing. What happens or what we record on the patient's chart can all be recalled in the court of law if they take a case to the court. All of that can be subjected to court documents. And so do not reference any incident report on their medical record. The incident report is separate from the medical record. And then you will need to review your facility's protocol over how to correctly document any medication errors on the patient's medical record. A lot of times, if you give a wrong medication or you miss a dose, there are things that can occur, side effects or outcomes that can occur for your patient that do need to be documented, but you need to make sure that you are doing this in the appropriate way according to your facility's protocols. And then you're going to evaluate your medication after you've administered a dose. So you'll evaluate your client or your patient's response to the medication. Was it a good response? Was it the desired outcome? Or was it an adverse response to the medication? You'll reassess your client. So you've given a blood pressure medication at 0700. It's now 0800. Their blood pressure was high before you administered that dose of blood pressure medication. You need to reassess your client now and make sure that their blood pressure has dropped to a normal limit. If it has not, then you may need to call the patient's provider to receive further orders to help their blood pressure decrease so that they don't have a stroke. Document your findings. Always document what you do. So once you have reassessed your patient, you need to document what it was that you assessed. Report findings if necessary or as ordered. So like I said, if the patient's blood pressure remains high, critically high, or the doctor said, give this medication, I want you to give them lorazepam now, call me in an hour with their response. So you would call in an hour and simply report to the provider that yes, this did in fact help Mrs. Q's anxiety, or no, it did not help her anxiety, and so then you may receive a further order. Identify side effects and or adverse effects. So you need to be aware, again, like I said, of this medication side effects and the adverse effects that it may have upon an individual, and then you need to be able to recognize those side effects or those adverse effects, and then you would promptly report those to the provider. Also, part of medication evaluation is monitoring lab results if necessary. If you are giving your patient potassium because they are on a loop diuretic, you're going to want to monitor your patient's potassium level. You need to make sure that they are within a therapeutic range. A normal level of potassium is 3.5 to 5.5. If you're giving a potassium supplement and their potassium was already 5.4 and you give X amount of potassium that day, they can actually reach a toxic level of potassium, and so then you would monitor them for hyperkalemia. And what are the side effects of hyperkalemia? One of those is abnormalities in pulse rate and rhythm, so they may have changes on their EKG. We need to monitor labs so that we know that our patients are maintaining a therapeutic level of whatever medication it is that we're giving them. So what does the FDA regulate? They regulate several different things. That includes foods, drugs, biologics, medical devices, electronic products, cosmetics, veterinary products, and even tobacco products. The FDA drug approval process is a lengthy one. Research into and development of new drugs is an ongoing process. The pharmaceutical manufacturing industries, they're multi-billion-dollar industries, and pharmaceutical companies must continuously develop new and better drugs to maintain a competitive edge. So the research required for the development of these drugs may take several years. Hundreds of substances are isolated that never make it to the market. Once a potentially beneficial drug has been identified, the pharmaceutical company must follow a regulated, systematic process before the drug can be sold on the open market. This U.S. system of drug research and development is one of the most stringent in the world. It was developed out of concern for patient safety and drug efficacy. Much time, funding, and documentation are required to ensure that these two very important objectives are met. Many drugs are marketed and used in foreign countries long before they receive approval here in the United States. Drug-related calamities are more likely to be avoided by this more stringent drug approval system. So there are several different steps that the FDA goes through before they approve a medication. The first step is the preclinical testing phase. This is where all new drugs undergo laboratory testing using both in vitro, or cells or tissue, and animal studies before any testing in human subjects can be done. In vitro studies include testing of the response of various types of mammalian, including human, cells and tissues to different concentrations of the investigational drug. In vitro studies help researchers to determine early if a substance might be too toxic for human patients. Many prospective new drugs are ruled out for human use during this preclinical phase of drug testing. However, a small percentage are referred for further clinical testing in human subjects. So then we enter into the clinical phase of testing. There are 4 clinical phases to testing. Before any testing on humans begins, subjects must provide informed consent, and it must be documented. Informed consent involves careful explanation to the patient or the test patient or research subject of the purpose of the study, the procedures that are to be used, the possible benefits to this medication and study, and then the risks involved with this medication and study. This explanation is followed by written documentation on a consent form. The informed consent document or consent form must be written in a language understood by the patient and must be dated and signed by the patient and at least one witness. Medical ethics dictate that participants in experimental drug studies be informed volunteers and not be coerced into participation in any way. Therefore, informed consent must be obtained from all patients or their legal guardians before they can be enrolled in an investigational new drug study. Research subjects must be informed of all potential hazards as well as possible benefits of the new therapy. It must be stressed to all patients that involvement in investigational new drug studies is voluntary, and that any individual can either decline to participate or quit the study at any time without affecting the delivery of any previously agreed upon healthcare services. So we'll talk about the clinical phase 1. Phase 1 studies, these usually involve small numbers of healthy subjects rather than those who have had the disease or have the disease that the new drug is intended to treat. So the purpose of this phase 1 study is to determine if the optimal dosage range and the pharmacokinetics of the drug, and to ascertain if further testing is needed for this drug. So they will perform blood tests, urinalysis, assessment of vital signs, and specific monitoring tests are also performed when they give this new drug. Then, if that medication passes phase 1 studies, they'll enter into a phase 2 study. Phase 2 studies involve small numbers of volunteers, again, they have to volunteer, who have the disease that the drug is designed to diagnose or to treat. These study participants are closely monitored to determine if the drug is effective and to identify any adverse effects. Therapeutic dosage range are actually refined during this phase. And if there's no serious adverse effects, the study then can progress to phase 3. Phase 3 studies involve large numbers of patients who are followed by medical research centers and other types of healthcare entities. The purpose of this larger sample size is to provide information about infrequent or rare adverse effects that may not yet have been observed during previous smaller studies. Information obtained during this clinical phase helps identify any risks associated with new drugs. To enhance objectivity, many studies are designed to incorporate a placebo drug. A placebo is an inert substance that is not a drug. Placebos are given to a portion of the research subjects to separate out the real benefits of the investigational drug from the apparent benefits arising out of the researcher or subject bias regarding expected desires or outcomes. If the study does not know if the drug he or she is administering is a placebo or the investigational drug, but the investigator does know, the study is referred to as a blinded investigational drug study. In most studies, neither the research staff nor the subjects being tested know which subjects are being given the real drug and which ones are being given the placebo drug. Then we enter into phase 4. If that drug then passes phase 3 clinical trials, it will enter into phase 4 clinical studies. Phase 4 studies, these are post-marketing studies that are voluntarily conducted by pharmaceutical companies to obtain further proof of the therapeutic and adverse effects of the new drug. Data from these studies are gathered for at least 2 years after the drug's release. Often, these studies compare the safety and the efficacy of the new drug with that of another drug in the same therapeutic category. Some medications make it through all phases of clinical trials without causing any problems among study patients. However, when they are used in larger general populations, severe adverse effects may appear for the first time. If a pattern of severe reactions to a newly marketed drug begins to emerge, the FDA may request that the manufacturer of the drug issue a black box warning or a voluntary recall. A black box warning is the strictest warning from the FDA, and it indicates that serious adverse effects have been reported with this medication. The medication can still be prescribed. However, the prescriber must be aware of the potential risks and the patient must be warned. Black box warnings are included in the prescribing information of the drug, and the text of the warning has a solid black border. That's the name black box. The goal of clinical phases is to provide on the safety, toxicity, efficacy, potency, bioavailability, and purity of a new drug. That would be the end of Module 2 for us. I would like you to answer the questions stated here. There are 8 questions. After you review this module, there will be an area on Moodle for you to submit the answers to your questions. Your questions are not due to be submitted until the 25th of November. I realize that is Thanksgiving break. However, you can submit them as soon as the 18th, but they are due on the 25th. After the submission deadline is met, I will then post the answer to these questions for you all. Thank you so much for your time, and I will see you guys in class face-to-face on the 18th. Have a great day.